Kathy, who has chronic kidney disease and who was very fortunate to receive a transplant at the beginning of July. I'm very pleased to say that she's very happy, healthy, and 100% a full back at work. Today, we have two people who are going to be presenting on their knowledge, background, experience, and technical expertise about living with glomerulonephritis. First off, we have Ruchi Ambike. Ruchi was diagnosed with IgA nephropathy in 2001. And strangely enough, between her time of diagnosis and the next time that she met somebody with IgA nephropathy was 22 years later in 2023. So this experience motivated her to connect with others facing this serious challenge. And she now serves as the lead ambassador to Canada in the IgA Nephropathy Foundation. So she dedicates a lot of her time to raising awareness, educating Canadians as to what IgA nephropathy is, and providing support in her professional life. Ruchi is a pediatric speech language pathologist, and she works with autistic children and their families. And our other presenter is Dr. Heather Reich, who is a clinician scientist, and I will pass it over to her to introduce herself and get ourselves underway. Dr. Reich.
Great. Thanks. Ruchi, did you want me to go ahead and introduce, or are you going to speak after me? Sorry.
Yeah, I'm going to speak after you, so you go ahead.
Okay, perfect.
Right, thank you.
Great, thanks. And thanks everybody for tuning in. My name is Heather Reich, and I am a clinician scientist, and I've dedicated my whole career for the last 25 years or so or more to glomerulonephritis. And it's a very exciting time in the glomerulonephritis world. I'm very lucky to practice at University Health Network, specifically at Toronto General Hospital, where I run the GN program. And I also am the director for nephrology for the University of Toronto, but I'm speaking here mostly as a GN doctor. A small disclosure that today I'm actually focusing on IgA nephropathy because this is where I get probably the most inquiries lately, and because there's a lot of movement and parts and a lot of evolution. So I'll outline as I go through some of the talk today about sort of how it could apply to other types of GN, because there are a lot of elements that are applicable across different types of GN. And even some of the medications that I mention are coming to trials for diseases outside of IgA nephropathy. However, we'll have to come back and make more of these talks. I'm happy to focus on other subtypes of GN as well. So hopefully for those of you who have GN or are interested in GN, but not necessarily IgA nephropathy, hopefully I can keep you informed and also interested, and I can point out where there are generalities across. So I'm going to share my presentation. And just make sure, Ruchi, could you give me a thumbs up if you can see it? Perfect. All right. So we'll get started. So today I'm focusing on IgA nephropathy, but as I mentioned, there's a lot new, but this is where there's a lot of attention. And the reason is that there's just an explosion in new treatments. And one of the themes is these treatments are very exciting. They're becoming more and more focused. So instead of treating with medications that are like a sledgehammer, we're now looking at more surgical precision on how we treat these kidney conditions. And the hope of that is to make treatments more effective, but also so that our people who take these treatments have less side effects. The more targeted our treatment, the more specific, and ideally, the less side effects that we have that are separate from from just caused by the drug itself and not by the kidney issue. There is a reason for why we have some, more development in specifically in IgA nephropathy, and I'll address this as well. I do do a lot of research, and I would say, I would say that a few years ago, this disclosure or conflict of interest slide would have been almost blank. And this is exciting because I do work with many pharmaceutical companies. As you know, GNs are rare, relatively rare conditions. Glomerulonephritis is probably the third leading cause of kidney disease that kidney specialists see in their practice in relative to the more common causes like diabetes and high blood pressure, although high blood pressure, whether that's something itself and on its own causes kidney disease is a whole other hour of discussion. But so it's relatively more frequent, but is still rare in terms of the absolute numbers of people that have these conditions. And so it took a long time for industry to get interested in developing drugs to treat these conditions. They also tend to progress relatively slowly. And so it was very difficult to do trials to find out if a medication works or not. But what's really exploded in the world of IgA nephropathy and is coming along in other conditions like FSGS and membranous nephropathy is that through research, we've discovered some endpoints that can happen early. And endpoints is what we call in a study, is what we look for to say, is a drug working or not? And if we can answer that within 1 or 2 years, it's way better than having to look at 5 years or 10 years to see that a drug is effective. And so now that we have these measurements that we can do at 2 years, some of the regulatory and government approvers, you may have heard of the FDA in the US or Health Canada in Canada, are getting more confident in whether the medication ultimately impacts someone's health. And with all that work, industries kind of jumped on the bandwagon and gotten very enthusiastic about developing new medications, but they don't have a lot of expertise in the area of these relatively rare diseases. And so I get asked to speak or contribute to a number of companies' plans. So the prologue here is really, really important. I'm going to talk about some general principles so that you have more knowledge and feel empowered and able to make decisions on your own. But I want to make sure that everyone understands that every person here is unique. IgA nephropathy, similar to membranous and FSGS, is by nature very different in every individual. Okay, so there's a wide spectrum of kidney disease that's all called IgA nephropathy or all called glomerulonephritis. And what works for you might not be true for others. So I can give some comments that may be applicable to you, but not necessarily the next person that we see in clinic. And everyone's path on a journey is unique. And everyone on this call is at a different stage of their journey. So I'll try to generalize, but in general principles, this is not any medical advice, and it might not apply to you. So I'm also going to be talking about research and treatments that are not yet approved in Canada. So that's important to know also. These are not, I mention a lot of names, but they're not necessarily approved. And we're still figuring out the safety data and risk benefit. At the same time, a lot of these medications are being trialed in IgA nephropathy and in other glomerular diseases. They're not yet approved in Canada, and so I'm glad to have a large audience today so that we can generate interest for advocacy so that we can bring some of these medications eventually to Canada once we have the best knowledge about their safety and how effective they are. And the last is just be hopeful. this presentation, I could never have, even 5 years ago, I looked at a presentation I gave to a patient group in the US 5 years ago, and it was 100% different. And that's really good news. So be hopeful, because there's a lot happening for glomerulonephritis to try to improve the outcome, symptoms, and just the way people feel. So I'm going to talk a little bit about anatomy of the kidneys and the biology with a focus on IgA nephropathy, a bit about what doctors look for, and if you're a numbers person and you want to follow things and you want information, this is what I would suggest would be helpful for you to look at or know about yourself or a loved one with GN. I'm going to talk about treatment, general principles of treatment, not necessarily totally specific, and the trials and situation with clinical trials. So just a little bit of a primer on the anatomy and biology. We have 2 kidneys mostly. If we have a transplant, there's one extra one, but we're all mostly born with 2 kidneys. Sometimes we're born with 1 kidney, and we can function for a lifetime with one well-functioning kidney. And you can see on the left side here that the kidney has, this is the larger view of a whole kidney. And you can see on the right in the middle is the nephron. And the nephron is really like the working unit of the kidney. And the nephron is made of 2 parts. One is the glomerulus, which is this little tuft of blood vessels. And the rest is the tubule. And the tubule is this pale colored tubing system that is filled with liquid that becomes more and more concentrated and eventually becomes the urine. So the nephron, or the workhorse, is comprised of the combination of the glomerulus, this tuft of blood vessels, and the tubule together. And when we have 2 kidneys, we have about 1 million nephrons at the time when we're born. And the conditions that I'm discussing today, IgA nephropathy, as well as all of the other forms of glomerulonephritis, affect the body as a whole. So both kidneys are going to be affected in the same way by this condition. This isn't a condition that just occurs in the kidney. It's the kidney is feeling the result of something going on in the body as a whole. I think that's the most common question I get is, are both of my kidneys affected? And this is just some drawings. When we look under a microscope, in the center here, you'll see this is what a glomerulus looks like. This is kind of a 3D drawing, and it's a tuft of blood vessels, but there are a lot of really specialized cells. The kidneys do a lot of things. There's a lot of information on the kidney website about what the kidneys do, but this is the glomerulus, because this is where the action is in glomerulonephritis. When you hear the word itis, like glomerulonephritis, that means inflammation. And I have a slide coming up that shows what I mean when I say inflammation. But when we have inflammation of this very special tuft of blood vessels and cells, we call that glomerulonephritis. And there are a variety of causes. And in IgA nephropathy, just on the bottom right here, you can see these little things that are called IgA antibodies, and these are proteins that clog up the filters of the kidney. Okay, and the whole filtering unit is the nephron, but specifically glomerulonephritis, we have damage to the glomeruli. And in IgA nephropathy, the IgA antibodies clog up the filter or glomerulus. So what are immunoglobulins and what is IgA? And I'll start on the left. You can see this is actually a drawing of what the IgA actually looks like. An immune globulin is also known as an antibody, and it's a protein that is made by our immune system. And the main function of immune globulins is to actually protect our body from invaders, from infections. And if you look at saliva, tears, mucus, and actually breast milk has a lot of IgA. IgA is the most common immune globulin in our body fluids, and it mops up germs like viruses and bacteria to prevent them from entering our bloodstream. And you can see on the right side, it protects the surfaces of our body, like the nose, lungs, and digestive tract. So IgA itself is a really good thing. We need IgA. We don't absolutely need it to survive. There are some people who are born without IgA, and they live very healthy lives. However, in most of us, it acts like a shield and is like our first weapon that prevents germs from entering our body. And normally, if I look at a filter of the kidney or a glomerulus, there's no immune globulin in there. It shouldn't be stuck in there. So in IgA nephropathy, the IgA protein, which normally helps us fight off infection, actually builds up in the kidneys and clogs up those filters. And we don't really know why, but in some people, the body produces too much IgA that we think maybe is sticky, and that makes it prone to stick inside those glomerulus in the filters. And this causes inflammation and damage over time. And that makes it harder and harder for kidneys to clean the blood. We don't know what causes IgA nephropathy. We don't know why it starts one day and didn't start the day before. But we know that in some people, there appears to be a trigger. Like people can say, oh, I noticed that this only started after I had a cold or a sore throat or an infection. And some people are also a bit more likely to get it because of genes that they have, because of their DNA, but it's extremely rare for it to run in families. So if someone has IgA nephropathy or the other forms of GN like membranous FSGS, it's very rare for them to pass it on to their children. That's very reassuring to some people. There are some forms of glomerulonephritis, like Alport syndrome, for example, that can be passed on to children in a more direct way, but IgA nephropathy, membranous, and FSGS are not. So what are the causes? Well, most of the time we just can't tell you. And someday, somebody hopefully will win a Nobel Prize and find out why we all have it. I have interest and do some experimental work in what causes IgA nephropathy. And we certainly understand way more than we did 20 years ago. But why it happens to person A at time A, we just can't give a clear answer that explains it 100%. And most of the time, that's a bit frustrating because we can't pinpoint something. Oh, if you only got rid of this, it would make things better. Rarely, IgA nephropathy can also happen in people who have other medical conditions. And so in that case, we call it secondary IgA nephropathy. And that would be some people who have chronic infections, like who have hepatitis or who have HIV, can get IgA nephropathy. Some people who have other immune disease, like Crohn's disease or rheumatoid arthritis, can get IgA nephropathy. If they have very advanced liver disease, and extremely rare, but if we see brand new IgA nephropathy in someone who is over the age of 70, sometimes we worry about an extremely rare reaction of the immune system to a cancer. But more times than not, this is no relation to a cancer. People are far more scared of cancer than they are of kidney disease. And this is just a reminder in general that all of us should be careful about routine cancer screening, but the most of the time it is not in any way related to a cancer. We learned a bit about the biology of IgA nephropathy by understanding that there seems to be it seems to be more frequent in certain parts of the world. And this tends to mirror where there are some genes that we think might cause some of the biology of IgA nephropathy. So by far, we see the highest rates of IgA nephropathy in Pacific and South Asian countries. And also there are a population of people in Central and South America who have a higher risk of IgA nephropathy. Of course, Canada, we're made up of very few of us are born in Canada. In Toronto, around 40% of people are not born in Canada. And so we see quite high rates of IgA nephropathy now from people who are recently arrived in Canada, but we also see plenty of IgA nephropathy in people who are born here. So I'm going to get back to this more complicated figure. This is a lot more about the this is about more about the biology details. And I don't want to get in too much into this, except to say that the very new treatments that we're going to talk about at the towards the end of this presentation are because we understand the biology. IgA is made by cells called plasma cells, and so which are a type of B cell. And we know that they respond and produce IgA when there are certain chemicals around. And so if we block these chemicals, and these chemicals are called APRIL or BAFF, if we block them, then we tend to get less IgA production. Similarly, on the bottom right, inflammation is important, and we have a system in our body called complement that causes inflammation. If we block inflammation, tends to be helpful for the kidneys. But I'll bring your attention up to the top left part of the slide here. Most of IgA is, we think, is produced from cells that are around the intestine and the airways and tonsils. And really, as I said at the start of this, is part of our healthy and normal response to defending our bodies against infection. Okay, so that's about where I'll stop with the biology. And I'm not sure, perhaps it would work if there are any quick questions about that section first. And I'll just ask you to actually, if one second, I can't see all of the comments. One
So
second.
If folks do have a question, you're welcome to raise your hand at the top of your screen. There's a little icon at the top, and then we can see your hand raised, and we can take you off mute and off camera to ask your question. Perfect.
So Leo has a question.
Thanks. If you can let people moderate, if you can moderate, that would be great, because I'm having trouble seeing both the presentation and the questions.
No problem. Go ahead, Leo.
Oh, hi. Thanks. So can you hear me, doctor?
Yes.
Yes. I mean, maybe you're going to talk about these medications, but because how it works of blocking APRIL and BAFF, do you think people in the new regime, people with IgA should be put on these blockers just like they would be put on ACE and ARBs as a first line medication rather than a second, third line, for people with progressive.
So that's a very, very, very hot topic right now. It's a great question and a very high level and kind of debated question. And so I actually have a lot about treatment coming up in the presentation, and hopefully I can answer that question. The short version is we have to wait till we see how these medications perform when the trials are all finished. But if they turn off the disease, then absolutely they should be a priority in most people.
Okay, thanks.
Yeah.
Thank you, Dr. Reich. Kathy Farron, you have a question.
Kathy has left. Her hand is not raised anymore.
Okay, so then we will go to the next person, and that is Taran Thacker.
Yes, thank you. Hi, Dr. Reich. How are you?
Okay,
Good
thank
afternoon.
you.
I hope you remember me. I saw
Of
you many years
course.
back in Toronto. Yes. So I was, thanks so much, for the presentation. One question is, so does research indicate it is not hereditary now, IgA? Because I think it's a bit of confusion because, as you know,
Yes.
I was just worried
So
whether
if we, yeah,
yeah.
so if we look at all patients with IgA nephropathy, probably 98% of people will have nobody in their family that had IgA nephropathy. Okay, so we don't. There are still some families, but they're so unusual families that we can't always, that some of them are even just reported in the scientific literature because we want to understand why it does run in some families. But 98% will not have a family member that also has IgA nephropathy. What is genetic about IgA nephropathy that's more common is that there are some genes that make people at risk of getting IgA nephropathy. And maybe that can tell us a little bit about how better to treat that patient in the future. But right now, because there's no clear inheritance within most people with IgA nephropathy, there isn't a genetic test for this condition. So it's not a condition like polycystic kidney disease, for example, where there's a clear genetic pattern and we can even predict how likely it is that people will pass it on to their family. When there are families where IgA tends to run, like families where we clearly see there's more than one family member and we see multiple generations of patients with IgA nephropathy, those are really the exception and not the rule. And in terms of genetic tests for those families, it becomes very specific to that family and probably isn't the same gene between one family and another family. So the vast majority is not passed on to the family with exceptions.
Okay, thank you so much.
Yeah.
Thank you, Dr. Reich. The next up is Kathy F.
Okay.
Kathy, you're on mute. There we go.
Yeah. Is IgA nephropathy a common type in lupus patients?
Lupus and IgA nephropathy are separate. So lupus is what's similar about it is it's a condition that can cause glomerulonephritis, lupus, and it also is a situation where your body's immune system or a person's immune system is kind of, I like to think of it that the immune system's a little confused. It's doing too much of what it's supposed to do. In this case, in IgA nephropathy, the body's making too much IgA. In lupus, the body is making too many immune globulins, but they're not just IgA, they're directed against other cells in the body. And instead of fighting off an infection, the body immune system is reacting against other cells within the body. So similar in the sense that both are considered autoimmune conditions, but different in terms of the organs that tend to be affected. And then the kidney biopsy also looks very different. So it would be a bit difficult. If someone has a kidney biopsy, you wouldn't really easily confuse IgA and lupus. So they're quite different conditions. Some of the treatments do overlap, though. So that is true, and some of the principles of treatment are the same. But they are different conditions.
Thank you for that, Dr. Reich. There are no more questions at this
Okay.
point in time, so you
I'll
can
get
continue.
going,
Sure.
and then I'll next pause at the kind of treatment section, at the end of the treatment section, because I know there's going to be tons of questions after that.
Wonderful.
So IgA nephropathy, just like membranous, just like FSGS, just like lupus, comes in many different flavors. Okay, and lupus actually, they had a really good campaign probably 20 years ago where they called it the many faces of lupus. And the campaign was a poster and it showed people of all different ancestry, gender, background, countries, all with one condition. And it was to highlight the thing that in every person it's different, and then people of all different backgrounds can get the condition. And IgA nephropathy, I think of in some ways along similar lines, is that there will always be people who are exceptions, and there are also a few different patterns that doctors see with IgA nephropathy. And so, for example, some people may be lucky enough that through their whole lifetime of IgA nephropathy, all they'll ever have is a little blood in the urine that they can't even see, a little protein in the urine, and minimal kidney damage over time. And that's just what they'll have on their plate forever, and never have anything much different than that. Some people will have just intermittently blood that they can actually see in their urine, and they get an infection, and the same time they see blood, like it really looks dark red or sometimes a bit cola colored. But in between these episodes, they're great, feel great, and their blood tests and urine tests are actually close to normal. I bolded this one because this is probably the most common presentation. And when we talk about guidelines and we talk about treatments and clinical trials, it mostly includes people with this face of IgA nephropathy, and that's a generally slow condition that has injury to the kidneys that can get worse over the course of years. And we're talking like 10 years, 20 years. So progressive, it's a serious condition, but it's not something that leads to kidney failure in a year, for example. So that's what I'm mostly talking about today. I also see patients every year who either are diagnosed very late or have very aggressive rapid condition with scarring that happens like over months. We know it started in January, and we know that by December, their kidneys are really heavily damaged, and this is more rare. We also know that IgA sometimes can deposit in the blood vessels of the skin and other organs, not just the kidneys. And on the right here is a picture of the rash that is called purpura, that is in people who have something called IgA vasculitis. The name used to be Henoch-Schönlein purpura. Within the kidney, it looks almost exactly the same, but patients will tell you it's not the same. They get this rash, they can get abdominal pain, and they can get joint pain, and it's more common in children. Sometimes the rash can be really annoying, and so that's one way that IgA nephropathy can look. And finally, IgA nephropathy, some of you may be dealing with IgA having come back in a transplant. And because it's a condition that affects the body's immune system, sometimes it can break through and can come back after a transplant, which is an extra challenge. So just to recognize here on this call, but also in general, IgA nephropathy itself, just by its nature, looks really different in different people. There's an even more rare version where people just have tons and tons of protein in the urine and get very swollen suddenly, and so there's different varieties that look very different in each person, but I'm mostly talking about the slow progressive one. Sorry, this went a little offline, but what are the symptoms of IgA nephropathy? Most often, there are no symptoms, and that's what we've classically said. And this is a bit different than some of the other glomerulonephritis conditions where, swelling is very obvious, or, there are more obvious symptoms. Now that we've done a bit more like rigorous study of patients and gotten their perspective, and certainly in my practice, I have such a large practice of patients with IgA nephropathy, I would argue that maybe no symptoms is not really totally true. It's very common that people will tell me that they have some fatigue. Could be the disease itself, could be just the stress and knowing that they have to deal with a serious condition that causes fatigue, plus the life and world we live in that's stressful. But fatigue, I would say I hear fairly commonly. And then like a vague low back discomfort. Kidneys aren't usually painful, but sometimes people who have IgA nephropathy have told their doctors that they have a little bit of vague low back discomfort. And especially they feel that at the times when they see blood in the urine, but even without blood in the urine, they may have a bit of vague low back discomfort. Doesn't necessarily mean your disease is getting worse. There are 100 different things that can cause low back pain, but we do notice that people have remarked and had these symptoms. People might notice frothy urine, and by frothy urine, I mean like lots of bubbles in the urine, and that's common to many different types of glomerular kidney disease, and sometimes means that there's protein in the urine or the urine is very concentrated. People might have some swelling. In IgA nephropathy, it tends to be less than other glomerulonephritis, but swelling in the ankles would be common, sometimes around the eyes, especially after indulging in a salty meal. There might be a little bit of swelling. And I showed you that photo just before of IgA vasculitis. Here people will experience more things like rash, belly pain, sore joints, and sometimes even some fevers and a bit more fatigue. Okay, so what do doctors look for? And you should probably be familiar with some of these terms if you like to be hands-on in terms of your treatment and knowing a little bit more about your prognosis. So this is what the doctors are tracking when they assess you at clinic appointment. And if you're a numbers person, you might want to keep track of some of these things as well. So I'll list these and I'll go into each of these separately. One is the biopsy pattern. So unfortunately, we still depend on a kidney biopsy to diagnose all of the different types of glomerulonephritis. Okay.
Excuse me, Dr. Reich. If you had planned on changing your screen, it still shows me.
The kidney biopsy is unfortunately the only way that we really can diagnose IgA nephropathy and all of the forms of glomerulonephritis. And in IgA nephropathy, we have something called an Oxford score or MEST score. And you'll hear a bit about that in a moment. Blood pressure. Blood pressure is something we can fix, and that's an important thing to follow. How well the kidneys are cleaning our blood. That is the creatinine, which is a blood test. And we use that blood test to calculate how well the kidneys are cleaning, which is called the GFR. And finally, how much protein there is in the urine, we think gives us an idea about how damaged the kidneys are. Some of that might be reversible, some of it not, but that is something that the doctors are tracking to help to see how serious the disease is and whether someone is responding to treatment. So this MEST-C score or Oxford score, this is all different varieties and how we look at the kidney biopsy under the microscope. These are the real glomeruli or filters of the kidney. And it helps us understand how much of the kidney disease is active and how much inflammation there is compared to how much is not really active, but is scarring and is maybe irreversible damage. So inflammation and scarring are two different concepts, and I think are helpful to know. Inflammation describes how your body protects itself when something's wrong. Like when you get a cut or catch a cold, your body's immune system creates inflammation to help fight off bacteria, to help heal wounds, to help heal damage, and it's really your body's alarm system telling your immune system helpers to come and fix the problem. So inflammation is easy when it's at the skin, for example. Your skin might get, when you cut yourself, it might get an infection there. You might notice redness and swelling at the beginning. You might feel some pain, and that's your body's immune system causing inflammation. That's part of the healing process. It's a normal part of getting better, but it can sometimes happen even when there isn't a real danger. And this is like when I say your immune system's a bit confused, and that can cause problems. And this is true in most types of glomerulonephritis, not just IgA nephropathy. Scarring scarring is like what we know what is a scar. A scar is what happens when your body repairs itself after an injury or like a cut in your skin. And your body replaces damaged skin or tissue with a thick new patch. But and that's what a scar is. But the scar kind of looks and works differently than normal cells and kidney tissue. And scars don't go away. You're stuck with a scar. So scar, in my mind, is what's no longer reversible. Okay, and that's damage. And sometimes damage, most of the time, we just cannot get back. A scar is a scar. Just like in the skin, the kidneys can scar and scars cannot be reversed. So that's where we talk about damage. And when something has heavy scarring, when the filters of the kidneys are heavily scarred, we see that they have difficulty cleaning the blood. And that's when our creatinine blood test starts to become a problem. When there's inflammation and not yet, as much scarring, we can still see the cleaning tests go a little weird, but we could also see blood in the urine and protein in the urine. So these are two related, but a little bit separate concepts. And the biopsy is really the best way for us to see how much is inflammation and how much is scarring. Nephrologists are numbers people, so we're going to talk about creatinine a lot. I forgot this reference here, but if you look at, I think it's kidney gfrequation.org, or if you Google it, I can give it to you after. It's one of our Canadian graphics on how you calculate kidney function. So creatinine, I hate to say what a normal creatinine is, but if you look at a lab report from all of our labs across Canada, you'll probably see something like 50 to 80 is considered normal. Too low is not really something we worry about, but higher it gets, the less our kidneys are cleaning. It's not a perfect measure of kidney function, but it's a good way of estimating it. And the doctor or the lab itself plugs this creatinine value into an equation that also includes age and gives a GFR reading. And it's not quite a percentage, but it's normal would be over 90. So I kind of like to think of it like a percentage and say, well, you have more than 90% kidney function, that's normal. As we age, we all lose some kidney function. And we now, for the sake of understanding and of finding treatments and doing research and communicating and providing education, we also talk about stages of kidney disease, chronic kidney disease stages, or CKD stage. So you might hear or read about this in your doctor's notes or discussions. And each stage, 1, 2, 3, 4, 5, corresponds to a GFR. Okay, it's and that's, you'll recognize some of that terminology. It is hard to say what's normal and not normal. There's one study that showed that something like 40% of people in Ontario over the age of 65 have a stage 3 kidney disease. And we know that can't be true, but it's partly because the age is included in this calculation. And just because, GFR is low doesn't mean it can't last for a long time. So staging is very important, and definitely people who have stage 4 and 5 chronic kidney disease can have more side effects from the kidney disease, but people can last within each stage for sometimes quite a long period of time. Lastly, protein in the urine. Normally, there should be absolutely no protein in the urine. Your body has the kidneys, those glomeruli are really smart. They're filters. They keep in the good stuff like protein. We need protein as a building block for our body. But when the filters are damaged, you can leak blood and protein into the urine. There are a lot of ways to measure protein in the urine. Everyone prefers doing it on the spot with a collection. That's great, but it's not as accurate once you have a fair bit of protein in the urine. So if there's a big decision to be made, or you want to be a little bit more accurate, or you're, once or twice a year at least, I recommend that people do a 24-hour urine collection for protein. It's a bit of a pain. You should get instructions on how to do it correctly, but that is another way of measuring protein. And normally should be in the range of, a small number of milligrams. But in IgA nephropathy, we see that this is one of our most important factors that helps us say how well a patient is responding to treatment and what their prognosis is. Protein in the urine doesn't always mean that the kidney disease is suddenly getting worse. So don't get too panicky about one value of protein in the urine that's higher than the other one. Very simple things like colds, infections, very heavy exercise, for some people really heavy protein meals, weight gain, blood pressure being high, can make protein in the urine go up temporarily. Okay, and we know that in IgA nephropathy and all forms of glomerulonephritis, the less protein in the urine, the better, even if it doesn't go back completely to normal. All right, so treatment. These treatment principles that I'm going to talk about today really apply to all forms of glomerulonephritis. I'll get a little bit at like which to put first, but they really do apply to everything. And of course, I am talking a little bit more about IgA today. So there are two main pillars of how we treat IgA nephropathy, two main areas. And they, in my mind, we should separate them just to make sure that we're doing a good job on both sides. Which one is more important depends on every patient. Which one to put first depends on many circumstances, okay? So it's hard to say for one patient, this should be done first, that should be done second, and this is evolving as our treatment options change. So what we have used for eons is what I call kidney protection, or people can refer to it as conservative treatment. And conservative maybe is not the best way of calling it, because it actually does an awful lot to protect the kidneys and the heart. And we've seen, dramatic improvements in kidney disease outcome, whether it's diabetes, glomerulonephritis, IgA nephropathy, FSGS, membranous nephropathy, or lupus, by using these kidney protection strategies. A lot of us don't know that really what's good for the heart. There's a lot of press about what makes your heart healthy, but all of those things are also really important for extending the life of our kidneys. When we talk about treatments that are conservative, we call them conservative because they tend to have much less side effects. They also tend to be less expensive, although that now is changing a little bit too. But they don't turn off the underlying disease, okay? Fixing your blood pressure is extremely important and falls into this category. But we know that it doesn't turn off the immune system, so it doesn't turn off IgA nephropathy. If you have lupus, treating blood pressure is extremely important, but we all know that if you lower the blood pressure, it doesn't treat the lupus. So it may not be enough for everybody, but for some people, it actually is enough, even in IgA nephropathy. So that's one half. The next half is treatments where we're really trying to modify or change or impact the underlying immune disease itself. And the new kind of catchword that doctors are calling it is disease modifying. And that's where we really are trying to affect the immune system and turn off inflammation, as well as immune globulin production, and really calm down and turn off the disease. Unfortunately, we still don't have cures for this disease, but if there's a way that we can at least put it into a remission or calm down the immune system. Now, calming down the immune system is might be very good for glomerulonephritis, but we need our immune system to fight off infections. And so these medications tend to be stronger, tend to be more potent, and tend to have more side effects. And so these are, very serious discussion about risks and benefits. They're also not a cure, as I said, and they also might not be enough for everybody. They don't work in 100% of people, and they don't work 100% of the time. But those are the main pillars of treatment. So how do doctors decide which to start and which to start first? Well, there are guidelines, and I'll talk about our guidelines because there's going to be press about that this month. Guidelines offer some suggestions. Lab tests and biopsy findings. Doctors will really look at these lab tests and help make a joint decision. These should be decisions that are made with the patient to see what's the best approach for you right now and you alone for treatment options. And in my mind, every individual has potential to be completely different. And we all need to put a lot of thought into these decisions because we have to balance the risks, the benefits, and the reality is whether you're in Canada or the US or China or India, we have to balance the costs of these medications and say, like, what's practical and feasible. Finally, there are a lot of other factors that might be different in one person from the next person. So someone may be very interested in pregnancy planning, and that will impact what we do. There may be more scarring on the biopsy and not much active disease going on. They already may be advanced kidney failure where we know there's going to be more side effects. Someone might have other medical conditions like diabetes or a history of cancer. And so all of these are very important. So there's no cookie cutter answer of which should come first, disease modifying treatment or conservative treatment. You're going to hear, if you're reading online about IgA nephropathy, that there's a new guideline that is going to be published actually next week. There's a very big meeting next week in Europe for the international IgA community. And coinciding with this meeting, these new guidelines will be published. Now, these guidelines are written for doctors. They're not written with a patient audience in mind, but they will be publicly available. There's an online draft from 2024 that's old and already outdated. And the one thing I will tell you is guidelines are not recipe books. So even doctors can tend to ignore like the individual person and just look at a guideline and say, oh, this is what I should be doing. But what's right for one person is not always right for other people. The last piece is, and I'm part of the committee I'm part of the group that wrote these guidelines. One thing is that the research trials have to be completed and published in order for them to be included in the guidelines. So there may be the FDA, the US, there may be some drugs that are conditionally approved, but they haven't published any of their research yet. Well, we can't comment on how good a trial is and how much we think it's going to help people if they haven't published their data. So in order for these guidelines for a medication to be included in these guidelines, there has to be publication of the data. And things change very quickly. This is just a timeline of some things that were published since the last version, just in 2021. And we anticipate that we're going to have to update these guidelines much more frequently because there's such an explosion of research in IgA nephropathy and probably soon in FSGS and membranous nephropathy. And as well, we know a lot of changes in other GNs like lupus. Okay, so I'm going to go now into some specifics about kidney protection treatment, the conservative treatment. I was playing with ChatGPT and I made this cute picture for kidney protection. So generally, lifestyle would be first. Most doctors, I hope, would much rather do something before giving a pill. And this is some things that we can all do for our health, including heart health, kidney health. It's not enough to cure IgA nephropathy. I wish I could say that there was some dietary change or something natural and easy. I can promise you that if there was something easy that we could all do, it would have already been done. But these definitely help lower make the kidneys stay healthy for longer. One is blood pressure, and we can help along with blood pressure by low salt diet, staying active, maintaining a healthy weight. Our kidneys are much happier when we don't smoke, when we don't consume excess alcohol, and when we avoid kidney toxins, things like anti-inflammatory medications like Advil or ibuprofen. I do tell people to be cautious with supplements. Supplements are not always regulated. We don't know what they have. We know that someone with this disease already has a pretty active immune system and may have an unpredicted reaction to a supplement. Healthy weight and lifestyle helps control cholesterol, which is good for the kidney and good for the heart. Fish oil, I'll bring up here. There's mixed results. There are some studies that suggest it works really well, some studies that suggest it doesn't do anything. I'd say, it's mixed results. It's not likely harmful. So sometimes lifestyle is just not enough. And there are actually many of the times it's not enough. And so we have to use medications to protect the kidneys. And there are some three main classes that I'll talk about. One is the use of medications that are called ACE inhibitors or angiotensin receptor blockers. You'll recognize them as like Ramipril, the drugs that end in -il, or the drugs that end in artan, candesartan, irbesartan. These are kidney protective, even when blood pressure is normal. So we do try to start these in everybody that has IgA nephropathy or glomerulonephritis that has protein in the urine. In some forms of glomerulonephritis, we don't start it up front, but in IgA nephropathy, we do. Cholesterol, we are quite aggressive with treating cholesterol in people, especially if they have more advanced chronic kidney disease and scarring in their kidneys. And sometimes diet is just not enough. We can't help it. Our genes just make cholesterol, and we use medications called statins. And finally, SGLT2 inhibitors, big name, medications are called flozins, and particularly in people who have stage 2 or more chronic kidney disease, plus protein in the urine, at some point in the course of their disease, not always right up front, but at some point during the course of the disease, we look at using these medications also to keep kidneys healthy as long as possible and potentially benefit the heart as well. There might be some other considerations. So pregnancy plans are important because these medications are not safe during pregnancy. We have some other new options that are licensed or partially licensed in the US. They're called endothelin inhibitors, sparsentan and atrasentan. The final data from these studies, at least from the atrasentan trial, are not yet available, but will be quite shortly. These do not turn off IgA nephropathy, but maybe offer a bit of extra protection on top of the medications I already mentioned. They are now extremely expensive, in the realm of hundreds of thousands of dollars per year, and are not available yet in Canada. Other considerations, so people who also have diabetes or have heart conditions might need to be on other medications for different reasons. We know that people with diabetes and heart conditions probably benefit from this class of medications like Ozempic, not just for weight loss, but for diabetes and the effect that it can have on the kidneys and the heart. But all the excitement is really in these agents that turn off the kidney disease and turn off IgA nephropathy. And before we or put it into remission, they don't cure, but turn it off at least temporarily. And all of these are very fancy, very expensive, and very few are available in Canada. So I'm going to start just with some of old-fashioned medication, which is prednisone. And some of you who have glomerulonephritis, in particular IgA nephropathy, will have been prescribed prednisone, and it's still around. It's very approachable in terms of cost. And it's based on really, really good data. The largest trial ever done in IgA nephropathy was done in patients who were given either a sugar pill or a variant of a type of prednisone. And we have very good data. I don't have to get into the technicalities, but if you look on the bottom right here, you see these rates, and you see the top in orange is people who got prednisone, and the bottom is gray. And we see that kidney function continued to go down and was worse in people who did not get prednisone, out to like 2 years after the prednisone. And so we know prednisone does work. And so I don't think we should feel like, prednisone is just not effective. It's not as good as we need it to be. Kidney function still tends to go down, and we can't give prednisone forever. The reason we can't give prednisone forever is because anyone who's been on it knows it has a ton of side effects. So things like making your appetite higher, cosmetic changes like face fullness, eye changes, vision changes, some bone thinning or damage, risk of infections, can make blood sugar high. And so there's a lot to prednisone, and we know we can do better than prednisone, but it is an effective medication to keep kidneys healthy longer in many people with IgA nephropathy. But because of the side effects, it's not given to everyone. And when there's too much scarring, we don't want to take the risk of all of these side effects. It's also not likely to be of much benefit. So I'll just talk briefly about the other approaches to treatment. I mentioned a lot of IgA is produced in along the lining of the gut and mucus, and actually our stool also has a lot of IgA in it, so that bacteria from our gut don't enter the blood. So I'm going to talk about some medications that act on the gut and IgA production, some medications that act on BAFF/APRIL, and some that act on complement. And again, these are all new. So in the US, it is fully approved, Tarpeo, which is a type of prednisone, but it's kind of unique. It's designed so that the body doesn't absorb much of it, okay? And so that keeps it intact in the gut, and that's where it acts, and it stops IgA production in the gut. Now, I will say that budesonide has been around for a long time, but this Nefecon or Tarpeo is relatively new because it was engineered to act in a certain part of the gut, and that's where the patent is. Right now, it is not available in Canada. Tarpeo is, budesonide's been around for a long time, and so there are other versions of budesonide that are cheaper, that are available in Canada, but we don't know if they work as well. If we look in the left side, this curve, the blue shows protein in the urine that comes down quite nicely in people who get Nefecon, compared to people who got a sugar pill in red. But Nefecon is usually given for about a year, and then we know that just like prednisone, protein does start to come back in the urine. We haven't cured this. And on the right-hand side, we could see kidney function is better in people who got Nefecon in blue. GFR is higher, but it doesn't totally stop coming down. It just looks better. So it does help preserve kidney function over time. It's not a miracle, it's not a cure. And some people do have a lot more prednisone, more side effects similar to prednisone. I've seen a few people who got quite a few side effects. And though they definitely still can get some of these side effects with Nefecon. Again, the cost is tremendous, and we just don't know if cheaper versions of budesonide are as good, but that is being tested in a very large trial in India. And I'll just close briefly because these are really research-based medications. These are the complement trials. In the US, iptacopan is available. It lowers protein in the urine about 40%. But they have not yet published all of their data showing all of the final effects on kidney function. And so they're not included in the guidelines, and it doesn't have full approval. And we can't really say until we have all the data available. We are part of this trial with ravulizumab. That's a medication that's given for other conditions. And sorry, this is an older slide. It's actually in phase 3 trials. And we have the ICAN study. So the Alexion produces this molecule, and we see this is exciting. These are part of affecting inflammation by shutting down the complement system. In the right, we have 2 medications one that didn't work as well as we wanted. So one that worked, but the company decided to stop making it. And next we have, people were already asking about the BAFF/APRIL drugs. There are different kinds. All of these medications lower the immune system, okay? So they all have a common risk of infection. There are 2 different groups of these drugs depending on exactly how they work. We don't know if one of them is better than the other. We don't know if one works better than the other. And none of them have published all of their data. We know that all of them probably lower protein in the urine, again, by about 30 to 40%. And we want to make sure that at 2 years, we see that kidney function is also preserved and better. And they will not be approved by the US until that happens, and won't be available in Canada either until that happens. The question is, how are we going to possibly pay for all of these medications? Each one of these is also probably 200,000 to 300,000 US a year. So we can't just send you across the border to get these medications and buy them out of pocket. We're going to need to rethink this and how we approach this disease and how companies price these medications. People in the US are getting them only if they have insurance. And some people are getting them with Medicare coverage, but our healthcare system cannot possibly support the cost of these medications when they're priced at that level. So I don't want to show the details of this, but it's just a slide that I use when I present to doctors that shows, different patients are going to be treated different ways, but the Ferrari treatment is, we have a few different drugs that we can use to turn off IgA nephropathy and protect the kidneys if we use a Ferrari version. Whether you're young and have very active disease, or whether you're a bit older and have more scarring. In Canada, I just want to show the contrast, not a lot of these are available yet. And some of that is true. We need the studies, we need the data, but this is also going to be a shout out for organizations and patients and patient groups to help advocate. And this isn't just lobbying our government, this is lobbying companies that make these medications to have them available at prices that our government can afford.
Dr. Reich?
All right. Is it working now? Can you see it?
We can, yes.
Okay, perfect.
Thank you, Jim.
Yeah, no problem. Thanks for your help there. First, I just want to really thank Kidney Foundation of Canada, the Ontario branch, for hosting the session, and also a lot of appreciation to Dr. Reich for taking the time to share so much important information with us. So I really appreciate that. So my reason for being here and sharing information is, as mentioned, I am a patient with IgA nephropathy, and I was diagnosed in 2001 and didn't meet anyone with the same disease as me until 2023. And that was at a patient symposium held by the IgA Nephropathy Foundation. And after meeting all these other patients like myself, it drove me to want to be able to share information, resources, and support about the foundation. And so I did train in 2024 to become an ambassador to Canada for the IgA Nephropathy Foundation. Basically, it is a 100% nonprofit that has global outreach, including Canada, where we just launched in May of this year. We did launch the network here as well, providing support, education, advocacy to patients as well as to caregivers and care partners. There's a huge focus on finding a cure for IgA nephropathy as well as funds research. And it was founded, and it's sort of important to know this, that it was founded 21 years ago by a mom whose son was diagnosed with IgAN when he was 13. And at the time, there was literally nothing, no information. And she made it her mission to want to be able to support people and also find out information. There's a free membership that gives you lots of resources and supports. And there is a lot of support for Canadians. So besides just meeting with others and making connections, they hold an annual patient symposium. It is in the States, but they offer a heavily discounted rate. So for this year, it was $125 US, and that covered the hotel stay for 2 nights, all the conference sessions, which were, these really great nephrologists, pathologists, and the meals and entertainment. So you get a lot just being able to attend. You get a lot out of it. There's also free virtual therapy through Talkspace. You get a free Calm app subscription. They have an app as well that you can find recipes, lab tracking, and a lot of vetted tools and information on their website, which is igan.org. Right now, the foundation is very committed to working towards treatment access for Canadians. So kind of like what Dr. Reich mentioned, that there are treatments out there. We don't have them yet in Canada. So we are really trying to work hard to advocate to get these treatments by, partnering and collaborating with pharmaceuticals, with other foundations and organizations, reaching out to MPs. So there's a lot of work going on to try to move this forward. And mainly there's just all that support. So you get lots of support from people who can understand what you're going through. There's other supports like financial aid. So subsidy is available to Canadians to travel and attend Spark. Monthly virtual support calls for patients as well as for caregivers and care partners. Updated information on clinical trials. They've just recently started clinical trials Tuesdays. So they send an email out with information, including trials running in Canada. The website, there's a Canada page on the website now where we're trying to populate it with resources for Canadians. There's a Canada Facebook page, there are podcasts, and then support from foundation leads as well. This is just some screenshots of some of the resources that you can find on the website. They are digital resources, you can print them as well. And then all their publications that they have as well are on there. It's really nice that, Kidney Foundation of Ontario helped to have IgAN Awareness Day proclaimed on May 14th this year, as well as last year. So it's just another way to spread awareness of this disease. And then connecting with the foundations. So the website information is there. I am available, if anyone wants to reach out via email. And there are other Canada ambassadors as well. So there are a few of us that are available to, share information with you. And that is, I can't figure out how to stop. Oh, I think I stopped.
You did.
You did.